we will start very early, just on time. So welcome everyone to another webinar of Conversations on COVID-19 series. I'm Hala Ali, the coordinator of Easter Alliance for Global Health Partnerships and Easter Ireland. And this webinar will be recorded and we will post it later on our website on the slides right now. And sorry. Along with the slides displayed during the webinar. And the live streaming is now also available on our YouTube channel, Irish Global Health Network. These webinars take place on Fridays at 12 p.m. GMT, and it's a place for people who are working in global health and healthcare, where we can exchange experiences and ideas with the experts in the field regarding COVID-19. Today, the experts will discuss North and South partnerships in the context of COVID-19. And then we will get an overview of the situation from Zambia and Colombia. On a related note, we are planning to host an online conference by the end of the month to explore the options open to individual clinicians and institutions in health partnerships so they can communicate with their counterparts in the other parts of the world. This conference will be organized by THET for Partnerships for Global Health and Easter Alliance, and probably WHO. And it will involve speakers from Africa and Asia, as well as UK, Japan, US, Ireland, and Germany. Nothing confirmed yet about that, but we will send more information in our newsletters. So if you are not a subscriber to our newsletters, please use the poll in the bottom of the screen, and you can tick the box and we will add you to our newsletters. If you have any questions during the webinar, please raise your hand and we will get back to you later by the end of the webinar, or you can use the question and answer feature in the bottom of the screen. Now, I will leave you with my co-host Nadine France and the Executive Director of Irish Global Health Network and Easter Ireland, who will then introduce the speakers and start the discussions. Nadine?
Yeah, so thanks, Hala, and welcome everybody. Great to have you on. Really excited today. We have quite a big number of really wonderful speakers today. And we have Ben Sims with us. He's the Chief Executive from THET Partnership for Global Health in the UK. Wonderful. Thanks for being here, Ben. We have Shams, who's sitting in the World Health Organization. At the moment, he's the quality team lead in WHO. He has been working since 2009 directly on twinning partnerships for health. So we're delighted you could join us, Shams. Thank you for that. We have Arle Gomez, who's the research director from Colombia, from the University Foundation of Health Sciences. And we're really looking forward to hearing more about the situation in Colombia. We are delighted to have Mwenya Kasonde from Zambia, who will be known to many of us as she studied in Royal College of Surgeons in Ireland. She is a public health consultant at the moment, and before that she was formerly with the Ministry of Health in Zambia as Assistant Director for Global Health, responsible for health partnerships in Zambia. So thank you for joining us. We have David Weekliam, known to many, former chair of the Easter Alliance, currently leader of the Global Health Programme in the Health Service Executive, and he has oversight for the Easter Ireland programme. And then last but not least, we have Rory Brewer. He's our webinar anchor, Professor Emeritus, former head of the Department of Epidemiology and Public Health in the Royal College of Surgeons, and an emerging, budding media star at the moment. He was on the show tonight. Last night. So Rory, we want to just start with you, if that's okay, and as we do every week, and just ask if you could give us just an overview, a context, where are we at, what's happening. Thank you, Rory.
Thanks, Nadine. You can hear me okay? And as Ellen is just pulling up the slide there, now we're going to go straight into the link at the bottom, which is the WHO overview. And just comment, Nadine, I'm probably going to go out of business because you've described me as the Emirates professor, and as airlines are going out of business, I will too soon. As you know, I've been trying to retire for a long time. So most of you, even if you weren't on the call last week, are familiar with the dashboard. It's just a little bit out of date. We know that there's over a billion cases now. On the right, then you can see which are the top countries. The US now is more than double the number of cases in Italy. Spain looks like it could well be a worse epidemic than Italy in terms of the upward trajectory. And China is falling behind and may well be passed out by Germany. So it comes as a little surprise. We just look at Africa once again because it's of a particular interest to us. And anyway, in terms of reporting test positives, not a lot is changing. South Africa is moving ahead as we expected, and Supra or Northern Africa is as well. But there's very little reporting going on, and that we don't think reflects what is beginning to happen and what will soon happen. So just on the next slide, just another one from WHO, and it just shows a picture of the epidemic. We see China on the left there, and in March, Europe took over in the red or the kind of light brown, and then the US up there at the top, which is likely to maybe take over from Europe at some point. Next slide. So here I just wanted to summarize, just looking back, a month is a long time. Even 3 days is a doubling of the epidemic in the absence of effective measures. And we can see just the rapid trajectory in these countries. There is the difference. If you actually work out the mortality rates, you see that China, which is a mature epidemic, has quite a low mortality rate of 4%. Italy is 12%. It looks as if the mortality rates in the US and the UK are quite low at around 2% in the US, but that reflects that it's a very early epidemic. And as these epidemics evolve, we're going to see much higher mortality rates. So the Irish mortality rate at 2.5% reflects that it's probably an earlier epidemic than the UK. Next slide. And here's just a summary. Again, the Health Protection Surveillance Centre is a good source of information. So we're talking a little bit more about the Irish epidemic today, and that's the summary of the data there. The low case fatality rate, we're beginning to see the admissions into ICU rising, and we'll see that in the next slide. And you see in the map of Ireland that well over half the cases are concentrated in Dublin, and this urban concentration would appear to be a major risk for countries across high, middle and low income countries. We're going to look at sex later because that was one of the requests, but you can see there at the bottom, very much an equal distribution of males and females with one of these growth charts that shows the older age. Next. So I'll just say a little bit more about this, and this is what I've been talking about a little bit yesterday in the media. And what is important is not the overall numbers, which is what people have been looking at every day as they come out in the evening and they're on RTE. Much more important is the patterns of transmission, and that will be true of other countries as well. And the community transmission rates there, there's somewhat different data from RTE and from the Department of Health. They've reclassified some of these in the data today. But we're seeing very much a generalized community epidemic now in Ireland, even though it's early days. And the aim of the epidemic, as Tony Hoolan has been saying, is to push, the aim of the control is to push the epidemic out of the community, back into households, back towards local transmission. So this isn't looking very good at the moment. The number of clusters, and within that, there's a particular analysis done on the 31st of March. And what's worrying in Ireland, and probably in many countries where we have a lot of old people in nursing homes, is the large number of clusters there and in hospitals. And then when we look at the specific issue of healthcare workers, and this is going to be an issue in every country and should be in any way the biggest concern, and we really need to be waving the red flag. And we see that there is an error in that slide there. Well, we see that the spread, the transmission to health workers that occurs in the hospital or in the nursing home or in GP represents only a quarter of the cases contracted by the healthcare workers. And the bottom one should read actually community transmission, not repeat nosocomial. 61% of transmissions are happening in the community. And I think that was why a few days ago there was an appeal to can we separate healthcare workers so that they're not all living in the same houses. It looks as if a lot of that transmission is happening outside of the hospital. PPE is a major issue in Ireland as elsewhere. And then we see the hospitalization rates, and even in the space of 2 or 3 days, we're seeing now the death rates are beginning to rise. Next slide. So, and Nadine said there was a request to just look at what are the differences, male, female, and there's not quite a lot. There's not a lot out there, but it's roughly in Ireland half the cases are male, half female. The healthcare worker cases are more, but that's because of the feminization of the healthcare workforce, particularly among nurses. But in Ireland, we don't have the deaths yet to have the numbers, but the ICU admissions are almost 3 times as many are male. And then the data from China, from Italy and Germany points to men being at much greater risk of death. 70% of the deaths in Italy were among men. Why? That's not clear yet. And there are some hypotheses out there that it may be behavioral, smoking, hand washing, not so much the workplace, because women are out in the workplace as much as men are. Could it be due to immune responses or hormonal responses? That's just a link to a Guardian article, which does link to one of the studies. Next. So just putting up this curve again, I can't do anything with it, but you'll see, and Ellen can point to it there. I just stuck in an extra line there to show where might we be. Well, we haven't reached the serrated horizontal line. We haven't reached the capacity of the healthcare system yet, but we are somewhere low down on the curve, and maybe the curve is somewhere between what's in the first large curve there, which is the epidemic with no interventions, where you overwhelm the health services, and the second, that blue curve that we're aiming for, which is to try and not flatten the curve. Mike Ryan has been correcting the language around that and saying, no, we're trying to push the curve down. And once you stop pushing the curve down, the curve goes back up again. And that's one of the quandaries we're going to be facing now. How long do we keep these measures in place? So I think the final slide now is next. And I think Ellen has looked at it, and she's going to just bring us into the link there at the bottom. And she's going to just scroll down the side there. And as we scroll down, this is maybe just an example of how the media can represent. Okay, we stopped there. So earlier we just saw the epidemic curve, and here we see the introduction of interventions, and these are the kinds of interventions that we've seen in Ireland, in most high-income countries, and some of these we've discussed are clearly inappropriate to countries in Africa, so just forcing people to stay in their homes for 2 or 3 weeks. So let's go down one more bit there now. And here, the same scenario, but shifted. So the interventions begin 1 month later. So the previous slide, I think, showed 4 million infections or 4 point something. A delay in introducing the interventions, and this is modeled for the US, shows a much higher peak of infections. We see the deaths below there at 666. It's rather ominous. And let's go down one more. And try yourself dragging the intervention bar. So Ellen will just pull the bar across. The later the interventions are introduced, the higher the peak of the infections. But look also, the deaths are increasing as well. These are the ones that are buying us time. The social, or rather the physical distancing. And let's just go down one more. And here we see, it depends. how severe or how rigorous and how comprehensive the interventions are. And Ellen, if you just click on mild, modest, and aggressive, you can leave and you see mild, not doing very much. Modest, we're pushing the epidemic down more, and aggressive, we're pushing it down more. So the two critical things we're facing are how well can we do these interventions, and how long do they need to last? That's the big question as economies are shut down. And the second point, which is of equal importance, is doing the public health interventions, because these are two arms to our response. The things we're doing in the population to lock us down or close us down are only one half of it. Public health measures, the identification, testing, big problem in Ireland at the moment, contact tracing, the isolation of cases and the contacts. And we're not doing it well enough at the moment in Ireland. So the family are just coming in the door, so it's a good point to stop, I think, Nadine.
Wonderful. Thank you, Rory. Okay, Rory, thank you. As always, so much food for thought. Hello, Louis. Welcome. Wonderful. Okay, so let's move over. David, if we can come to you, if you can just kind of put your, we've talked a lot about what's happening, the current situation, and we want to look at health partnerships a little bit. A number of institutions, hospitals and institutions in Ireland and in European countries have been and are currently partnered with institutions in low middle income countries all over the world. So we want to focus a little bit and talk to you and to the others about what, can you tell us a little bit about why are partnerships important, and what should we be doing at this time in terms of COVID? Thanks, David. We can't hear you, David. You need to unmute yourself.
Thanks, Nadine. Hope you can hear me now, and good afternoon, everyone. Yeah, just to start by saying a little bit about the ESTRA Alliance. And as Nadine said, this involves many different institutions in Europe that since 2004 have been working in institutional partnerships. So we sometimes refer to them as twinnings with counterpart institutions in low and middle income countries. And these institutions are engaged in a wide range of technical activities in areas like infectious diseases, non-communicable diseases, maybe groups like people with disabilities, and working in different ways, collaborating to improve healthcare and to improve health outcomes. And maybe just to maybe say what a couple of the key features of these partnerships, I would say maybe firstly that it's about working as institutions rather than as individuals. So rather than going in as an individual and providing technical assistance, this is about looking at how to strengthen a whole institution, so that institution is stronger and more effective. And that might be through improving quality, it might be through education and training, improving information or other systems. And then maybe the other, I suppose, fundamental part of institutional health partnerships is the partnership. It's what it is to work in partnership and how we work in partnership. And that's about the relationship between the institutions. And this is about having a shared vision between institutions to work together and a commitment to work together to improve health. And I think that what this typically involves is a long-term relationship. And this is perhaps how partnerships can differ from just going in and working in time-bound projects. So I think now we're suddenly confronted with the pandemic. We're suddenly disrupted in what we do. We can't travel. So what do we do? And I think my first response to that is to say really that I think at this time, this is the time maybe more than ever when we need to maintain our commitment and our solidarity with our partners. This is the time they need us most. This is the time we need to be there for them. And even if we can't travel, then the question is, how do we do that? And I think a number of us will be, quite mindful of, even in recent times, say after the Ebola crisis, going back in to work with partners when we weren't there during the epidemic, and the challenge with the relationship there. We weren't there at their time of greatest need because we couldn't be there. So how is it at this time that we can be there for our partners when physically we can't be present? So I think that's what we're focusing on today. And maybe there's kind of three questions in my mind. One is, which aspects of our partnership activities can we continue? The second question is maybe which activities do we need to suspend or stop at this time? Maybe thirdly then, what different activities or new activities might we undertake with our partners that are of particular help to them, you know, in this particular situation? And one thing I'd say is that it's important for us not to just press on with our projects. We may have, you know, scheduled timelines, but it is not the time to stick to them. I think one of the key features of partnerships is flexibility. We should be flexible and respond and adapt to the needs that our partners have. I think this is what being good partners is about. So I think this means discussing with our partners, what is it they need at this time? Do we need to adapt what we're doing? Maybe we need to reschedule some things, do things differently. And we may in some cases need to go back to our donors and say, is it okay? We need to maybe reuse our funding for a different way to meet what's more important at this time. And just to give an example from my own kind of work, where some of our key partners are in Ministry of Health in Mozambique and in Ethiopia, and we're keeping in contact with them. And one of the things they've said, they'd like to continue with some of the quality improvement supports for their hospitals that we're working with them on. And some of that we are able to continue, at least at the moment. We are able to continue coaching webinars and online learning. So for now, some of that is continuing. We're also asking them, what is it we can do to help them at this time? And some of the response that is to ask some questions, and for us, asking us to provide information where they have questions about some aspects of what maybe they need to be doing for their own planning and preparedness in their countries. Mm-hmm. So helping them with maybe making sense of some of these other guidance documents that are there, and helping them to understand how can they best implement guidance and what are the appropriate things they can be doing in their countries at the moment.
Yeah.
And maybe just one thing, just really to emphasize, I think one of the most important things this time is good communication. Mm. And I think I find myself much more regularly communicating with the partners. Sometimes it's just WhatsApp messages, or maybe sometimes Zoom calls, just to be in touch, say we're thinking of them, are they okay, is there anything we can do to help? And just so that we are trying to maintain that commitment to them and to be there to support them as best we can, and trying to work out with them, what is it we can be doing that's of value for them.
Mm-hmm. Thank you, David. David, we might leave it there and come back to you if that's okay. And thanks for that. And just to remind everybody who is watching, if you have any questions, please pop them into the Q&A at the bottom of the screen. Please pop them in there, and we will try and direct them and answer them as best we can. I might move now to Shams in the World Health Organization. And, you know, just to say, obviously WHO has been supporting partnerships for years as an approach. Shams, from your perspective right now, what's the potential for these partnerships in light of what's happening in terms of COVID? And you might even speak a little bit around essential health services.
Sure. Thanks, Nadine, and good afternoon, everybody. Rory gave a very nice overview of the epidemiology, the situation, and the interventions in relationship to COVID-19. One of the things that we'll also have to be cognizant of is the projected epidemiology, and that's something that partnerships, of course, needs to consider when they're looking at what is going to happen in the immediate, medium term, and longer term. So in terms of what the potential role of partnerships might be, it's a very pragmatic role, and just building on what David has just highlighted, it has to be pragmatic, and it has to be directly relevant to the frontline everyday needs that are emerging. So technical exchange to meet the immediate need at the institutional level, learning for action, so also packaging that learning so that we can spread that as quickly as possible to reach the maximal number of people. And then finally, and David's highlighted this already, but that solidarity piece, I don't think we can underestimate. So solidarity through compassion, and compassion for each other, irrespective of geography, and of course, compassion for the patients and the communities that we would serve. A point of emphasis is, of course, our focus on identifying, isolating, and caring for patients early, including providing optimized care for infected patients, is, of course, the urgent need. But at the same time, placing strong emphasis on maintaining essential health services and maintaining the quality of those essential health services. We'll make sure that we provide the link to the most recent WHO guidance on maintaining essential health services, but it does lay out in a very simple way the overarching principles are related to maintaining essential health services. But the pragmatic aspects of that and the nitty-gritties, partnerships are very well placed because they know the realities of the front line. So that's something that I think we should really take careful consideration of, is the burden of disease attributable to COVID-19, and at the same time, the burden of disease attributable to all of the other conditions, the everyday conditions that we have to face. And in that, the domains of quality become really important. So is the care that's being provided effective? Is it safe? Is it people-centered? If we get to a situation where people no longer trust the services that are being provided, then we're going to lose thousands, if not millions of people for not accessing the services that they needed to access. And at the same time, thinking about the timeliness of the service, the equity dimension critical, and the efficiency piece, but very pragmatically in terms of a partnership and their understanding, and ensuring that the services are integrated. So all of these aspects, they're complex, but I think the partnership community is very well placed to be able to keep us grounded, not in conceptual documentation, really important, and of course, normative guidance is critical in this situation, but we need to keep grounded on the operational realities, partnerships, and the relationships that develop over time. Nothing could be better. One final thing that I wanted to mention, and these are the types of stories that are often forgotten. It was actually a partnership that developed the capacity in the University Hospital FAN in Senegal for infection prevention and control. And it was contributing to the capacity of University Hospital FAN. The one case of Ebola that was a part of the West Africa Ebola crisis that emerged in Senegal was shut down incredibly efficiently by the workers in University Hospital FAN. That's an example of the long-term effect that a partnership can have. In that case, it was with the University Hospital in Geneva. Just a few thoughts, Nadine, looking forward to the conversation.
Yeah, thank you, Shams. Really interesting thoughts. I'm just thinking, I might move to Ben, if that's okay, just on terms of health partnerships. I mean, THET has been training and educating workers in Africa and Asia for many, many years. And currently you're supporting over 130 partnerships between the UK and low middle income countries. You know, what kind of things are you currently doing as an organization, as a team? How are you, what's the situation for the partnerships? I know it's very early days, but what are you seeing, and what are you anticipating, particularly because, the UK, like other countries, the health capacity in all of our countries in Europe is highly stretched at the moment as well. So maybe just to hear a little bit from you, Ben.
Thank you, and thank you so much for having me and inviting me to contribute. And yeah, I mean, one reaction is that I'm just blown away. So I was not expecting, at a time of crisis in the UK, when we don't feel as a country that we're on top of the pandemic, I was not expecting people to be coming to me talking about what's happening in Africa and Asia. And yet they are. Because to echo David and Shams, these are pretty special people who get involved in these partnerships. And somehow, over and above the daily job, they find the energy and don't forget the friendships that come through partnerships. I'm thinking of, for example, King's College, Centre for Global Health Partnerships, who with us responded immediately to a request from our colleagues in Somaliland. The Somaliland Ministry of Health, it was about PPE. They needed some equipment rapidly. They needed a bit of advice, and without hesitation, King's stood up and are providing advice. And King's, of course, have a track record here. They did a similar thing when Ebola happened in Sierra Leone, and We have Oliver Johnson's wonderful book, Getting to Zero, as a kind of record of that intervention. So, but they're not alone. I mean, the Royal Society of Paediatrics and Child Health in the UK are continuing to do training using Zoom technology to GPs in Myanmar. And it's not also on a big scale. So one person I've been incredibly impressed by, who I think many of us know, is Catherine Thomas in Wales. She's a GP. She has a link with Lesotho, and she had restricted funding, echoing what someone was talking about earlier. And she said, forget the restriction, spend the money. And it was 1,500 UK pounds,
Right.
not a lot of money. The point was, the best money is the money given without restrictions and given early. And I think one of your guests, the Irish doctor who's in Malawi, made the same point in an earlier webinar that you held. So we're seeing fantastic amounts of very practical activity happening. We then did a survey of 20 partners rapidly overnight, and we're trying now to do that more methodically, but all of them were maintaining that contact. David, I thought you spoke so well about the value of that contact and what you're doing as an individual basis. I was delighted that all of the partnerships were maintaining that contact. Not all of them knowing quite what to do.
Mm-hmm.
Some of them kings, operating very confidently, others not so. But I think there are two areas, as we've said, where support can be given. One is the sharing of clinical expertise, but the other one is the expression of solidarity. And when we think about the mental health and challenges that are falling on health workers in the front line in all these settings, China, the Lancet study that we all read recently, in the UK and Ireland, etc., we know that the pressure on health workers in the front line is going to be immense. And there is a role for us in expressing solidarity and support.
Yeah, thank you, Ben. And I see somebody is just asking there, cooperation is key because everything is moving so fast. And how can this kind of cooperation be built fast? I mean, from a partnership perspective, those partnerships are in place, right? So what would you say to that?
So I'm very excited about some things. Now, if we look at the funding, the extent to which THET can contribute will depend on how successful we are persuading the big players like DFID to cough up. But already we have private donors who are coming on side to allow us to create a rapid response fund. It's exactly that kind of money that we think we can distribute quickly and on I like to use the phrase trust-based principle. And how do we do that? We do it through existing health partnerships.
Right.
So the health partnerships have the relationships. They've filled out the log frames, they've done the forms, they've provided the receipts. We know their track record in terms of using money responsibly. And therefore, I think health partnerships now are a fantastic conduit for rapid flows of funding. So we've raised £20,000 so far. We're hoping that we'll raise more. We've got a couple of, I'm saying this partly to encourage everyone else, a couple of companies that are interested in supporting us. I think in some ways that's also been a lovely surprise that in the midst of the epidemic in the UK, we do actually have corporates, we have members of parliament who are thinking about the tsunami that is coming towards Africa and other parts of Asia. And I think that partnerships, because of all the things that we've said, are just a brilliant conduit for getting money rapidly into the hands of health workers, which they are best judged to know what to do with.
Brilliant, Ben. And if there's people here listening, I mean, through, for instance, the THET program in the UK, Esther Europe, there's different places they could go, Esther Ireland, you can find out who is working in partnerships and maybe start a conversation with those organizations. Thank you, Ben. I'm just going to move on to, we'd love to hear more from Zambia. Mwenya, you know, you have this unique view of Ireland and Zambia, just from your own personal experience, and obviously being on the ground at the moment in Zambia. Can you tell us a little bit about the current situation? What's happening, and what are the greatest challenges that you see at the moment as you are early in this?
Hi, thanks. Thanks, Nadine, and thanks for having me. This is just a very important conversation to have, and I definitely think you all did very well to organize this. So just a small caveat, I'm not currently in Zambia, I'm stuck in the UK.
Got it.
I can't actually get back. I'm dying to get back soon, but I've not been able to for several reasons. So the situation in Zambia, so we have 39 cases recorded currently as of this morning. I noticed your number said 36, or was it the WHO number said 36? We're up to 39 now. And unfortunately, we've recorded our first death. Yesterday, we had one patient who unfortunately passed away from complications of COVID, and this particular patient did have a respiratory history. So we've certainly not been spared. The African continent seems to have been slow to be hit, but we certainly have not been spared. I also pick up on your commentary about testing and reporting. I wonder if that's one of the reasons why we may not be having as many cases, because we're simply not testing as many and we're simply not finding as many. Out of those 39 confirmed cases, we're talking of roughly 800 tests having been carried out in Zambia. So you can see that the numbers that is there, you know, are obviously quite different to many other parts of the world. Nonetheless, the ministry has been very proactive in this, and I have to commend the leadership in Zambia, the government leadership, the presidential leadership, and indeed the ministry and the minister himself. We're very much taken on a healthy normal approach, meaning that we've come together as well. Government has come together and involved several different players. So by that I mean the Ministry of Education, the Ministry of Communication, Information, Broadcasting have been very good at giving out messages, you know, to the public about this. Water and sanitation, even more traditional religious leaders, etc., all have really come together. You know, really multi-stakeholder approach and coordinated approach in the fight against this very unfortunate pandemic. As far as specific measures, like the rest of the world, we've enhanced security at points of entry. Now, the interesting thing for us is that we've been so cautious about Ebola recently, that we've had to enhance security, healthcare security anyways, because we've been under the threat from Ebola for such a long time. So we've been monitoring temperature for all travelers, you know, as a response to the Ebola situation that was particularly sort of dangerous for us because we had a lot of Ebola coming from the DRC just north of Zambia. So these have really just complemented the efforts that were put in place as a result of us trying to fight the Ebola threat. As a country and as a region, and again, why I'm enjoying this conversation so much is because we talk about partnerships, and we actually host as Zambia the Regional Collaborating Center for the Africa CDC. So we've been working a lot within the region and seeing how we can work together to come together as Southern African countries and coordinate and fight our efforts. Now, with regards to, again, specific interventions like the rest of the world, we've put ourselves not quite on complete lockdown, but nonetheless, public gatherings are restricted. The president announced that he wanted bars, nightclubs, cinemas, gyms, and casinos to close. Several international airports have been closed. In Dola Airport, for example, which is where the copper belt is, where a lot of our mining sort of traffic would normally come from. That airport has been closed. Symptomatic travelers are being quarantined, etc.
And Mwenya, what would you say in terms of, like, if there's organizations already partnered with Zambian hospitals and health institutions, how could they best support at this time? Anything specific in terms of just thoughts on that?
Sure. I mean, other than the obvious sort of donating PPEs, for me, I think it's important for us to look forward. I'm a proponent of research. I think it's very important in this kind of emergency. We tend to neglect the data a little bit. We tend to neglect the research a little bit because we're so bothered about the clinical aspect, and rightly so in many ways. Ben, you mentioned King's College in Somaliland, and funny enough, I actually brought King's to Zambia as well. They were here. They had been in Zambia for some time, but part of my work while I was at the ministry was was strengthening the partnership with King's College and the Ministry of Health in Zambia. So those kinds of academic and research partnerships, I think, are really, really crucial, especially at a time like this. I appreciate that we do need to deal with this emergency in every way that we can, but I think the research partnerships, to me, are really important. I think it's important that our systems become stronger out of this and not weaker.
Right.
And just to agree with you very, very quickly, I think there's learning to be had for the UK and Zambia in these kind of partnerships. So I've been delighted the Royal Free, for example, developed a critical care pathway during their project in Zambia. That is now being shared with the London Critical Care Network, specifically to induct people who haven't been involved in critical care into those processes. So it's a really good example of how sometimes health partnerships are fertile ground for innovation, which can then be rolled out, not just for the benefit of Zambia, but for the benefit of the UK.
Yeah. Thank you. Thank you, Ben. Thank you, Muanya. Thank you so much. I'm just thinking, lastly, just want to move over to Colombia, to Dr. Arley in Colombia, and just ask you if you can just also comment, Dr. Arley, on the situation in Colombia. So we're kind of just painting a picture of where we're all at. So we'd love to hear from you, Dr. Arley. What is the response looking like? Where are you at?
Okay, hello, everybody. Thank you for having me here in this seminar. So I want to have a really different approach in terms of talk about the unknown enemy. Second, about the variability of the clinical features that we have worldwide, and it's also depending on health systems as well. And last but not least, talk of course about South American and Colombian situation. With the aim of really be sure, I should mention that this is the fastest genome ever done in a couple of days, 3 days in France and so on. Why? It's an important tool to molecular epidemiology to track where the contaminations comes from and how we can control. And you have talked about the linkage between communication and institutional strength to work together. And I fully agree, because that really overpassed the decision from the government. It's not about only health ministers. They need expertise working together to help them to take bigger decisions. So actually what we have had is that even though we have the full genome of those enemies, we have a lot of interest about the mutations, and apparently up to now there's no mutations that are threatened in terms of virulence and killing of the virus. Second is that we don't have a long-term data, so we don't know about the long-lasting immunity, and it's a big concern related with vaccine. In terms of the clinical features, we have that has been described the mild, the severe, and the critical symptoms, and around 20% of the patients will develop severe disease. But there are highly variability nowadays in the period of incubation of the disease. And also, it's changing also the clinical starting point, for example, from the neurological point of view, from the intestinal. Now we have, for example, one of our colleagues in the intensive care unit with air ventilation, but the first symptoms were digestive. We have also some patients with oral symptoms. So it seems that the quarantine will work, but it's what I call a social vaccine, because with a short expire date, because it cannot stand for longer.
And Dr. Arley, right now, Dr. Arley, in terms of Colombia, what are the challenges that you have right now with what's happening there? Could you just speak a little bit to that?
Yes, well, actually, with the cooperation with the Prevention Medicine Institute in Switzerland, we made a collaboration to try to make a model of what will happening and advise the government about the impact in terms of facilities, in terms of the health system. And what we have done is what you can see might be in the graphics is that we calculate that apparently with all the controls, we can have at least a number of 2,000 cases, 2,800. And I think that if you can come to the next slide, please. Next. And that's the picture up to now. We have 1,161 cases, 19 death fatalities, and apparently it's in an equal proportion from women and men. But what we need to strengthen is the cooperation in terms of institutions, because the communication is a key point in there. Since it seems that the curve is flattening right now, but the 2 weeks ahead are really an important issue. See if the measures works or not. And certainly, I wonder if that prediction of the number of facilities that we need is about 5,720 beds for patients, that out of these 5,000, 1,716 should be in intensive care units. And as you know, there's a lacking of ventilators everywhere. Now we create a calling application from the science ministers in which engineers are working together in different universities to create new devices. And of course, we are trying to work together as a intelligence network to create new epidemiological and public health measures that can control, because we need to be aware that this is not for a short period of time. It will last maybe for a year at least. And we need to have short time measures, middle term measures, and long term measures. So with this calling application, we have developed more than 538 projects in which the aim is to contribute to the government to solve the situation.
Dr. Ali, thank you for also just highlighting the importance of research and how you're already, through your research partnership with the organization in Switzerland, already moving to focus on this and the modeling. Thank you for that. And I think somebody just, Linda mentioned, which I thought was a really interesting, important point, is, there's so much that we can learn from our partners as well. For instance, in Uganda, they've got some great examples of great health and information communication sharing in the past around biosecurity. So, really good to be looking for those examples. I might come back to you, Shams, just to ask, any inputs. We've heard a little bit from Colombia, from Zambia, from Ireland, from the UK, and the situation is similar in many different countries. So just in terms of what you've heard, Shams, maybe talk a little bit about, why the quality of health services, how can we focus on quality at this time when things are moving so fast? You're muted. You're muted. Yeah.
Great. Thanks, Nadine. Yeah, in terms of everything that's been said, it's an incredibly rich discussion. And in some ways, our focus really has to be on defining the most immediate need, right? So based on the trusted partnerships that we have, what is the most immediate? And one of the ways of looking at immediate health service needs is through a very clear frame of reference related to the quality of health services. And just expanding on just a couple of points that I was mentioning earlier, if we think about any of the domains, each of the domains of quality provide an entry point for a partnership to work on. So when just going through, and I think this is familiar to most of you, but essentially in terms of clinical effectiveness, both for COVID-19 patients, but also in maintaining essential health services, fundamental and critical, but of course, adapted pragmatically to the frontline needs. Second, of course, is the patient safety agenda. Without a doubt, we again are falling into that situation where a facility that is supposed to heal may harm. And that's something that we need focused attention on. And then the third domain, the people-centeredness domain, is very important for us because again, that trust in the health facility, if that is deficient or if it depletes over time, then the utilization of the facility and the service will diminish, and that in turn will lead to mortality and morbidity. So just focusing in on those three domains, but importantly, I personally feel that the health workers that participate in a partnership are incredibly well placed to articulate what the priority is in each of those domains, and then apply rapid cycle improvements in those specific areas. And it's a huge undertaking to prioritize within an incredibly stretched and stressful environment. But often when it comes to actually dealing with chaos, what do people naturally do? They increase their level of activity, right. But often it's a matter of pausing, thinking strategically about what the immediate intervention can be, but also thinking about what the medium-term intervention should be. Mm-hmm. That's where and of course we all hope for this, is that as time goes on, we are going to get into a recovery phase, God willing, and that's going to be the time for us to build back better.
Yeah. Thank you, Shams. And I think just your point as well, it's like, you know, all of us are experiencing this increase in working and trying to support and trying to adapt quickly and still be creative and focused. And in all of that, just looking after, you know, it came up in the last few webinars, looking after your own mental health and doing what you can to stay grounded, to, you know, to, if it is to keep routines in your days, to notice the balance, you know, and to get the support, to get help in whatever way makes sense to you. So I think that's really important for all of us. And when you just last words, really just coming around to everybody, just anything that you'd like to leave us with as we continue on, and particularly for many of us involved in partnerships with Zambian organizations. You're on mute. Yeah, go ahead.
I think much has been said. I think Shams has raised an important point about health-seeking behaviors. What we do sort of as leaders and as change makers is going to affect people at the grassroots, and that's really going to have an important impact, especially when we talk about health-seeking behavior. You know, people are watching, you know, how we react to this in terms of it's going to affect how people do go for testing, not just for this, but for any other type of condition. Yeah. So I think the importance of remembering the effect that this is going to have on health-seeking behaviors is important.
Thank you, Menya. Dr. Arley, just a last word from yourself.
I think the most important is that the worldwide real-time cooperation and communication is a key point, because we have seen all over South America different patterns according to the governments. For example, Brazil, it's still neglecting the importance of quarantine and other measures. Yeah. And for example, Ecuador has really been the worst situation, in which even deaf people are standing outside of the houses. But I think that we can share all our knowledge, all our resources and communication, that will be the best.
Great, thank you, and thank you for sharing all of yours with us today. I think that's exactly what we're doing here. So thank you for that. Ben, just coming to you, just to last some words for us.
Well, I think my thing is, think for a moment about the billions of pounds available to those of us who, by fluke of birth, happen to be living in what we sometimes call the global north. The billions of pounds that's underpinning our economy, our health services, and just close your eyes and think about Africa. This is going to be an economic disaster as well as a medical disaster. It requires unprecedented levels of solidarity and generosity across countries and across borders. And I think that partly why, Hala, to go back to the beginning and your reference to our conference at the end of this month, partly why we're motivated to organize that is to be part of a movement, the health partnership community, to be part of a movement crying out for that greater justice. This is a time when we really need to step up financially to support the poorer countries of the world.
Mm-hmm. Thank you for that, Ben. David, just coming to you.
Thanks, Nadine. Yeah, I think three things struck me particularly from the discussion today. I think one is to our partnerships, the direct link we have to healthcare workers in lower income countries, and the opportunity there to really be very practical support to them. They work in such challenging situations, and when you think of their lack of access to resources and PPE, etc., and the risks they face, I think for us to be able to keep linked to them at this time, I think is really important. The second thing was around information, and Sean spoke about packaging information about immediate needs. And I think this is a role we can play in serving our partners, is where there's so much information now being developed from so many different sources. Very, very difficult, I think, for people on the ground to assimilate everything. And if we can help just to pull out some of the key messages for them, key piece of information, and really help them tailor maybe some of the global guidance for their particular contexts, where they have less resources, I think that can be very useful. Mm-hmm. And finally, just following Ben's points and about the need for us to support Africa. I mean, and I was really pleased to hear how this, the expressions of support in the UK that he spoke about. But as our countries become under more pressure in the coming weeks, and as maybe our health systems start to feel more overwhelmed, there's going to be an even more intense kind of preoccupation with just what's happening in our own countries. And I think we can all be advocates for support for other countries. And I think one of the things that was said in recent days was how the global response is only as strong as the weakest link. And we all have a vested interest in this pandemic be controlled everywhere. So it's in our interest in Ireland for this to be controlled in other countries, in less developed countries. So it's in everybody's interest. So we can't just consider our own situation in Ireland. We need to kind of keep mindful of the bigger picture. But we've a role to play in advocacy, I think, to try and make sure that we don't become just too inward looking, trying to just deal with our own problems.
Yeah, thank you, David. And I think, for many healthcare workers who've been working, say, from Ireland and other countries with partners in countries like Zambia or other countries like that, it hasn't been maybe as, we've not had to deal with a crisis here to the same extent as we're dealing with it now. So I think in terms of solidarity and understanding of context, I think we have a greater opportunity at this time to be able to work together like that, especially for healthcare workers. Deirdre from COSEXA has just highlighted that COSEXA have made some educational resources free on an online e-learning platform for healthcare and non-healthcare workers in sub-Saharan Africa. So the URL is there. Rory, just a very last word from yourself, if we can, and then we will close the webinar. Thank you.
Thank you, Nadine. I think it's more of a request that we collectively try, and collectively working with WHO, can we identify the response to the COVID epidemic in low-income countries, particularly among our African partners. I mean, I wholly endorse what was said earlier about protecting the health workers and protecting the existing health services. I am still not clear. I'm not clear that in many high-income countries we can actually achieve what we're setting out to achieve, which is to suppress the epidemic for another 12 to 18 months or whenever a vaccine is going to appear. And I'm listening to a woman being interviewed on the TV last night from Kenya saying, I've been told I have to stay at home for 2 weeks. This is the bag of beans I have to feed my 11 children. This is the oil I have. And I have to go out and live. So I think there's a lot of unanswered questions. I don't feel I have the answers, but collectively we need to work on them.
No, thank you, Rory. And we're just going to continue these conversations as we can, as we go, without necessarily knowing what the conversation is, but just keeping this conversation. So thank you. I'll hand back to you, Hala.
Thank you, everyone. And thank you for all the speakers for this amazing webinar, which was really useful for everyone. And by this, we come to the end of the webinar. So I'm just remind the audience if they can fill out the evaluation form. It's in the chat box. and we really appreciate that for our coming webinars. And next week, the webinar will be about lessons learned from HIV, Ebola, and other pandemics, and also the role of behavioral science in combating epidemics. If you have any questions, please send them in advance to this email. And just a second. And thanks for attending, and we hope to see you again next week. And this webinar will be posted later in our websites on the screen and also on our YouTube channel. And don't forget to check our COVID-19 portal. It has the most updated news about COVID-19. Stay safe, everyone, and see you next week. And thank you, everyone.
Thank you, everybody.
Thank you.
Bye.
Bye. Bye.